monthly now, or every 3 months. I can't recall how often, but the meeting is really to showcase all the great work that's happening across the organisation around quality improvement. So there is a lot of great work. Obviously, this meeting can only showcase 2 or 3 at a time. But as Alison said, there's a lot more information on the microsite. There's also information on the intranet, and obviously keep a watch out for the social media, which will be informing you of other things that are happening across the organisation. But the other thing that's happening as well is obviously there's a lot of training. So if you're not trained, or you've come because you've got an interest in QI today to see what other people are doing, do go ahead and look on the microsite or the intranet. It will give you information about all the other opportunities that will be available to you in terms of building your skill. And really important that we make sure that we are building the skills across the organisation. I'd say the other thing to say, as well as, even if some of your colleagues have not made it today, it'd be really great if you could also spend the time talking to your colleagues about what you saw today, and obviously to build some interest and enthusiasm for QI, but also coming along to hear what other people have done across the organisation. So just to say thank you very much for you all being here and really interested on seeing what we're showcasing today, Alison.
Thanks, Natalie. So today we have 2 presentations, one from Dr. Mohammadi. So thank you very much for coming. Do you want to move to the agenda, please, Sean?
Sorry, my laptop now doesn't want to move forward. There we go.
There you go. So this project was around improving physical health monitoring recording in the Haringey East core team. We will have chance for discussion and questions and answers afterwards. And then we've got quite a different presentation, which was from the Adult Community Single Point of Access in Barnet, so the SPA in Barnet. And this is really showing how things can be spread using QI across an organisation. And we welcome Lee and Emily for that. So if we move firstly to Dr. Mohammadi, welcome.
Hello, can you hear me?
Yes, we can. Thank you.
Can I share? Okay.
I think we've got your slides on the screen.
Okay. So my name is Dr. Mohammadi. I'm Ali Mohammadi. I'm working East Community Team, Haringey. It's a general adult team, and I'm a specialty doctor. I was involved in this quality improvement since January 2024 up to September. And the reason that I was interested, initially I was a physical health champion in the team, and I was teaching nurses or care coordinator or those people who are interested in physical health about the basic 9 physical health parameters. Then when we check on Rio, we noticed that most of these, a significant number of our patients, they have no information on their records in terms of physical health. For example, no record of blood pressure, height, weight, these basic things. And basic blood tests like hemoglobin A1C, cholesterol, high density cholesterol, and the smoking status, drug and alcohol, these 9, and body mass index, BMI. So we were thinking with our team, how we can improve the recording of it, because initially when we check, it was only 20% data was there for all the patient, all CPA. Enhanced CPA means patient who have been care coordinated. So around 350 patients. So only 20% they had full, assessment. But again, this data was one-off, never been updated. We know that now, that we should update it every year. But data was there, for example, it was 4 years ago, 3 years ago. Whereas significant number of patients didn't have any data at all. Even like 4 years ago, they didn't have nothing. So we thought that possibly what we can do, then this in addition that we know that people, particularly with psychosis and severe mental illness, a significant number of mortality, possibly as a research shows, 50 to 20% died prematurely, because I know could be a various reason, but most likely because of this physical health problem as a result of taking long-term antipsychotic with metabolic syndrome, like high weight gain, high cholesterol, diabetes. Then we become more interested in just improving, at least rating it, because if we don't have the data, how can we then do the next step to go forward and find these people, liaise with the GP or other physical health services to improve their physical health and quality of care, life. So that's why our incentive, what to do. Then what I checked randomly, I did a quick audit in the team, and I noticed most of our team members, particularly nurses, that got limited knowledge of these 9 parameters. They know that they normally check when they see the patient, for example, do you smoke? They ask this question, but it was not organized to see where to put it, how to record it, and what's the significance of what is important, why we should record this. So what we did, we agreed, we had a meeting that I have 10 to 15 minutes supervision with them to explain these basic things, with them. And slowly they become the mindset that to start checking these 9 parameters more routinely and record it. We show them how they can record it. There is a physical health monitoring form on Rio, and how they can check whether a patient has been updated, the physical health parameter or not. Then again, there is a link on Rio that they can check it, that physical audit schizophrenia. I don't know whether you're familiar with that. If you go to Rio, a patient front page, several links right side of the front page. One of them, it says audit schizophrenia. If you click on that, and then the patient, for every patient, it comes up whether it's updated or not. If it's not updated, nothing there. If nothing there at all, no information you can't see. And if there is outdated, the date, for example, is belong to 2023 or 2024. It's not within 1 year. So they started checking the patient, and slowly we had more presentation in the team, in the clinical governance, 1 hour with the whole team, managers. And also when the mass came, we try to actually use mass. You know that mass is like a dashboard of checking or having a overall picture of the key performance of the team. And there is a, on the right side of each individual patient, if you go to the mass, you can see there is a circle in front of physical health, in addition to, for example, crisis plan, dialogue plus, other element. So we check also, in addition to the first way of checking, another option was using mass. And then mass, if it's black, the circle, or red, it shows that physical health parameters are not there or outdated. It's not updated. Then we can take action to choose those patients as service users. Then we decided again what to do. We chose several PDSA plan and keep recording, and then again going back to see what the pitfall is, whether this work or not, choose another PDA, for example, getting help, how to get access from GP. Some of these medical record is, we can find it from GP. The previous one, some people, they don't engage with us properly, but they engage better with the GP. And we check on LCR, and we managed to obtain those information, recent blood tests from GP for those people who actually was not engaging with us. For example, a patient is on antipsychotic and every 6 months coming over, but most likely goes to the GP most often than us. So we try every way to find this data in terms of blood pressure or basic blood tests. And then this is the plot that we came here, is a rand plot. You can see initially when we started, it was 20%. And then each month when we check, we were checking it every 2 weeks. Yeah, every 2 weeks, initially every week, and then every 2 weeks. And then you can see it was not a persistent, progress. It was like up and down a bit. That is because when we reflect on that, because initially some of people were not familiar what to do properly, then when they get it done, and we had a lot of, in terms of staff, some of our staff were locum and were leaving our team. So this is some not is changing here, is above the baseline. You can see here. Then, but from May, you can see is upstairs. It's going up slowly, spark of it, and then become permanent. Then we reach here to 40%, which was our objective. We were supposed to, from January, this is our plan, from January 2024 to September 2024 to reach 40% or 20%, to reach 40%. The reason is because we didn't want to be very ambitious in terms of, because people still was new to this system and they didn't know. Some of them were ambivalent to engage. I personally need to prompt them, to encourage them. We had meetings several times in a month to discuss and again repeat it. And what's the pitfall is, how we can help, for example, from other services in here in St. Anne's Lock Wellbeing Clinic. Some of our patients, were interested to do blood tests here rather than to go to Northmead. Then we talked to Wellbeing Clinic manager, they agreed. We sent them to them for blood tests, routine blood tests. And also where we were in the middle of this quality improvement, the trust actually recruited 2 physical health nurses just to do it. Again, we have more resources now. And in case some of people, that are reluctant to go to well-being clinic, we have got nurses here in our team. They are rotating amongst different teams in St. Anne's in the community. And then 1 or 2 days per week, they work with us and we refer some of the patients who are interested coming here to them, and they do the blood and the basic physical health things. Then now in the next step, we are going to improve it. Now at the moment, today, I did another quick audit. Now we are 54%. We moved to 54, means 14% more than September, since September 2024 until now. But we are hoping to do another one. Unfortunately, I was away for a few months. I was not involved. And I know that, again, 10 to 15 people, new people coming, and several people gone. So this is another problem we had, because it takes time to teach and train new people, how to work, what does it mean, what's the significance of it is, and how they can put this information where on Rio. So it takes time to get used to it. That's why it's going up and down, but I think we are improving. We are steadily improving. And then we receive support from Callum, who is Haringey advisor, is very supportive. I personally discuss with him, and he's happy to come to our meetings. And also, I took this opportunity to actually present this project here to get feedback from you. I'm sure you have more experience, and then to see how we can improve it even further. Yeah. Is there any question?
Thank you, Dr. Mohammadi. Does anybody have any questions at all? Any comments? Iona.
Thanks, Dr. Mohammadi. That was really interesting to hear, and definitely applicable across lots of other different services as well. One thing that was really nice to see is that you looked again at what that percentage is, and seen that it's gone up, so showing that that work has been sustained. And I think some of the points you made were really relevant to lots of other QI projects, about really thinking about how we can make it as part of the system rather than being reliant on people. So we know that if we do have turnover of people, we have it in our usual systems of physical health is one thing that we need to check. So that's maybe something that we can keep thinking about. How do we make sure it's business as usual, so that as people change or rotate, we're still making sure that we keep hold of those good practices that you've put in place. So thank you.
Thank you.
That's a really good point, Iona. But it was interesting to see one of your simple ideas about including it in sort of those discussions with staff, and the impact that had on them being able to look at the physical health parameters. So obviously part of the monitoring, yes, but also that training and supervision is so important. Natalie.
So a really great piece of work. My question is, how are we scaling it up and ensuring that others are learning from the work that you've put in Haringey?
So do you mean in other teams? Yeah. I recently, one of these foundation doctor contacted me a few days ago and wanted to know. I'm going to, I sent it this summary to him, and also another SPR from Camden and Islington. They contacted me, and they were very interested into doing the same things in Islington in their team, to see, because they say we have the same problem in terms of limited data on physical health. And they contacted me. They said that if you send us your project to us, the brief, a summary of your project, I did. So I think if we manage to actually do it trust-wide, it would be very helpful. And as you said, if you manage to embed it in the team somehow as a routine thing, despite whether, irrespective whether turnover of the staff or not, still should be there. It's like something being done routinely. It would be fantastic. Then based on that, we can actually help people more in terms of physical health. We can quickly, everybody can have a look, say, look, this patient is diabetes. A new doctors coming to our team, for example, a new junior doctors, as seen, for example, want to choose a new antipsychotic if the patient is diabetes, and we have this information, preferably not using olanzapine or those medication causes diabetogenic. So maybe goes for lower side effect medication. And in terms of checking and monitoring is very important as well to have this information. Yeah.
That's really excellent to hear that others have now contacted you to understand exactly what you did to be able to scale that up. So thank you so much. Any other points, questions for Dr. Mohammadi? Nope. Well, thank you very much for presenting with us, and I hope you stay on for the next presentation, which is from Lee Saunders and Emily Barber about the adult community single point of access. And this was all to do with the programme in Barnet to start with. So I'll hand over to Lee and Emily first.
Thanks, Alison. So I'm going to take this first slide. So as you can see, we've got quite a sort of wide membership. The SRO for this programme is PALMGIC. So I'm just going to talk about the sort of objective of the programme. So the idea of the SPA programme is basically to sort of enable nationalised and streamlined referral pathways, which would support identifying mental health needs and making sure that those people receive, the most appropriate care through screening the referrals, and then determining where they need to move on to in terms of sort of secondary care specialist services, and which are the most appropriate pathways for them. So a big part of our programme of work is around the sort of key metric that we're using, which is referred to in the SMART aim. So it's to screen all referrals within 72, to screen 80% of referrals within 72 hours. So essentially referrals are non-urgent referrals are made, they come in, the screeners do a desktop review, and then the decisions are made about where those referrals go. So this is supporting looking at NCLs and NHS England strategic goals. It's thinking about how we can sort of most appropriately use our staffing resource, and basically making sure people get to the right part of the system as quickly as possible. Could you move on, please, Sean? Thanks. So we've got a driver diagram for Barnet, as with all the boroughs, they've all got a driver diagram, and for each borough they have different things going on, different change ideas, etc. But this piece of work is focused on Barnet's go live, which went live, I think it was the 4th of April. And so during that time we've been able to achieve a change score of 4.5. Which is essentially based on that Power BI dashboard and Power BI metric, which I just talked about in terms of the 80% of cases within 72 hours. So we've created maps, so the as is and the to be maps, to sort of like guide our service areas on what the SPA map and the SPA pathway should be. which has been, quite a useful tool in sort of terms of not only making sure that the SPA pathway is correctly deployed, but also that it enables us to sort of think through how it impacts on other parts of the system, such as for Barnet. They've got the wellbeing team, and also thinking about their assessment function in the core teams. We've also held a series of workshops, and we've also had a clinical model group going since sort of September last year, I believe it was, or October. And that was a fortnightly meeting to basically bring people across the trust together so we can talk about, key factors such as the standard operating procedure, the single referral form, and get some sort of consistent and some consensus around decisions about how this tool might be, how the programme will be deployed. I'll hand over to Lee now.
So in this section, really, we just wanted to talk about a specific part of the programme, working with implementing SPA, and particularly with QI. I think we couldn't today present our whole driver diagram with all the changes that we're working through. So we thought we would focus on a particular area today, just to talk about it. But it is a big program, I have to say. And today what we thought we would talk to you about is standardisation of documentation across the trust. Because one of the first things we found within the clinical model group that was convened to look at changes that might be required in order to implement our SPA model was the fact that we really had different documentation for pretty much everything across the 5 boroughs. And one of the first things we decided to do was have a focus on a single referral form across the trust. And our starting position was that each division had their own referral forms, which were different in both format and content. Some were very long, some were very short, and it was really there was no consistency there. And our aim was to improve the quality of information received and use the form to collect additional information at source, which included a focus on gender, disability, sexual orientation, religion, and also our patients who were veterans. It also, with the changes that came up through the clinical model group and within our QI programme, we were also able to introduce, make changes to the risk assessment part of the referral form, which included introducing a risk assessment checklist and a section on physical health. Our aim was to improve the GP's experience by having a digital version of the form uploaded on the EMIS systems in each borough, which would facilitate and enable more efficient transfer of information from GP services to our own information services. So that was really all the aims and the conclusions we reached, and the changes that we made. And so we were able to agree with all of our colleagues across the divisions on a single referral form, which was implemented and we worked closely with our colleagues in the ICB. And as we roll out SPA in the individual divisions, what goes alongside that is the use of the new single referral form, and which is uploaded on Rio, and obviously that's the plan. In Barnet, that was there and available from the 4th, I think the 4th of April, when we went live with the system in Barnet. And so we were able to focus on this within our QI program because we were using that from the start. They're going, for the most part, we get very few any of the old referral forms from GPs now. They are going in, you know, we've got good evidence that they are going in. The referral forms we're receiving are the new form. We don't have much feedback, which might be a good thing actually at the moment, because there's certainly not a lot of negative feedback coming from this. But we will be conducting some surveys with our GP colleagues via the ICB, so that we can actually get their opinions of how they're finding it and whether it's how useful it is to them, and also if they have any recommendations around changes around the forms now they've been using them for some time. We would intend to share that feedback from the GP surgery within the clinical model group and also across divisional QI projects and updates. So it was a good start in terms of picking on something that was really important, that would underpin SPA with some consistency in our approach. And so we are about halfway through that program now, and that's but we will be rolling out SPA in Haringey next week, and they will start with the new form from then, and then in December Camden and Islington will follow, and then we'll expect to all be on the same page as far as that's concerned. So should we go to the next one? So just before I just talk about data, I suppose I should say, in terms of measurement, just to underpin the measurements for improvement. The reason why we did this is because we believed that these changes to the referral form would result in more timely screening and processing of referrals, which of course would enable the SPA team to meet its and targets that had been set. But we also felt and believed that this would result in early decision making in pathway selection, which would enable service users to be transferred to the right services as early as possible in the pathway. And this not only relates to transfer within our own services, but within SPA we are able to do quite a lot of signposting to external services as well, and provide feedback to GPs to give advice around the pathways. And so we believe that would be that there would be positive outcomes from a change of this nature. So today what we're bringing to you is we are sharing with you a copy of one of the dashboards we receive. It's we have it and we share amongst the services. We have a weekly dashboard. We also have a cumulative overview as well of the year to date, but this particular one is a week, and in this particular one it shows that we received 83 referrals. 70 of those were processed within 72 hours. But it's important to note that many of them were actually processed within 24 hours. We don't break it down any further, there's good evidence around that. And I think it's very important for us to report that the service often achieves far in excess of this in terms of compliance, because within Barnet we're almost working in real time now. The way the services work, the referrals are received, they're uploaded on Rio, they're allocated straight away to the practitioners, and the next day usually all of the cases are cleared. So for us, it is demonstrating that we are able to make decisions quite early in the pathway for a lot of people, and particularly, I think, to be able to direct people to core teams for further assessment quite quickly as well. And going forward, I think that we will engage with some more extended QI work with core teams around the assessment part of the pathway, so that we will be able to track and monitor through. So we will also, so it's good news in terms of speed of processing. We will also be undertaking some internal audit regarding the pathway selection, and looking to get some internal feedback from our colleagues in other services. We are gathering some information currently around the number of cases that are going through to core teams, and what impact that's having as well. So I think it's a start. It's not the whole, but it's certainly a good start in terms of introducing some service delivery, some service improvements that can be rolled out across the whole trust. So I'm not going to say too much because I'm conscious of time. So should we go, Emily, do you want to go on to the next slide around sustainability?
Yeah, thank you, Lee. So this is just talking about next steps, etc. So we've got a working draft copy of the standard operating procedure in place, which is what we're implementing across all of the boroughs. Once we become one whole SPA, then that will become the standard operating procedure to which that pathway works to. Obviously, we've got the single referral form, which we've talked about. We've also recruited, or are in the process of recruiting, 5 Band 7 practitioners to each of the SPA boroughs. We've also got a dedicated email address which is associated with the single referral form, and is the one that is used to send in the referrals. We've also got a SPA task and finish group, which is basically looking at the all of the protocols, standardized letters, so that everything is the same across the board, across the trust. Obviously, we've got our Power BI dashboard, and there's also system updates and configuration changes within Rio for the staff taking those referrals in. So the next steps for the SPA is basically, as I just said, to roll it out across all of the boroughs. And in terms of scaling up, we've got our QI model, which is basically being rolled out as we go to each borough. We use a standard sort of approach to what we've already drafted, but then we adapt and change it as we move into those different areas, because every borough is different. And also there's a big piece around sort of sharing our learning as we've gone forwards with the boroughs as we move into them, and reflecting backwards. So I think that's about it. So if anyone has any questions.
Thanks, Emily. Thank you, Lee. Do you want to take down the slides, Sian, for a minute so that we can see? Does anybody have any questions or comments? Neha.
Thank you both for sharing that incredible work and the results that you've achieved as well. And I was wondering if you, when you're reflecting back, think that there was a difference because you used QI tools and methodology and so on, as opposed to perhaps doing things where you would just kind of do it, which I think perhaps might have been something more traditionally done, at least in my experience, previously, without actually thinking about using QI.
I think yes, we did notice a difference. I think when we started the project, and some of our colleagues will have engaged early as well in the process. I think we were doing QI, but we weren't recognising that we were doing QI because we were doing the right things. We were engaging with people, you know, we were seeking opinions, we were looking at our baselines and saying, where are we at? We were doing all of that. But I think what QI does help us do is formulate our thinking around that and understanding the journey, that where you start from and where you end up to is what would be my view about it, actually. And also it enables you, I think, to capture a whole program because what we've realized is there's so many elements to this program that, you know, we're talking about one small part of it today, which is a referral form, but we've mentioned lots of other elements of this program. And the other thing I think with the QI approach is we can share this with the colleagues in the divisions as we go through. And one of the things that I've been quite conscious of is there's a lot of, obviously, there's a lot of standardisation and there's a lot of similarity in terms of the approach that we would have and the service that gets delivered. But what we are finding with a QI approach is that there are also some things which are unique to different services, you know, and within the boroughs. And it does allow us, I think, as well with the QI approach to tease those out and capture those, because, and one of the things we're trying to do is, because obviously we don't want everybody to do the same project, because, you know, we talked, you know, some of the things we get trialled in one area, rolled out in the others, but it's also other things come up in areas. You know, in Enfield, we're particularly learning things, the differences for those services, because they work under a Section 75 agreement. And so they would have some things that they might look at to do with the safeguarding pathways, which are different, you know, those sort of things. So I think the QI approach allows us to gather our information in a format that's manageable, that we can manage and think about it in terms of the improvements we want to make and work through how we can achieve those in the different areas. That's
Thanks,
me.
Lee.
Yeah.
Karen.
I'm really sorry I joined late, and so I missed most of what you had to say. But Lee, I'm really interested in your experience as a team and how much support you got from your managers, and did you get protected time? And I'm sorry, I don't know your role, so I'm really apologise, but I'm just interested in what the support was generally for you.
So I'm the interim manager for SPA.
Well, that's helpful then, isn't it? So your managers are on it. What about the higher up ones from there, though?
So, well, yes, we have been well supported in terms of rollout of SPA. There is a steering group. We've had Alison was one of the people that has been supporting us.
They got reasonable support then.
Yeah, we got good support. And Emily Birch. I mean, actually, I suppose part of the thing about the project is that from an early stage it was established, you know, key personnel that we could go to for different elements of the programme that we would need to approach for help if we needed it. And actually, you know, we had really good engagement from senior clinicians, you know, in the clinical model group, which was good as well. And when we started our QI programme, I, along with some of my other colleagues, were very keen to make sure that people felt enabled to engage. and we, made sure that we were there with them, and that because we had our practitioners involved, we had managers from interface services as well, and to have that dedicated space and time for people, and for them to feel that everybody's opinion was valuable, in the process. So we did try, but I'm not saying it was perfect, because there were some weeks when meetings should have happened and they didn't happen because there were, pressure around delivery for SPA and things like that. But for the most part, we tried to make sure that everybody who was engaged felt engaged, and tried to, we hope, spread the word about QI a bit more in the service as we went through. Yeah.
Okay, thank you.
Thanks, Lee. And I think it's worth saying that even right back in the beginning, Lee, there were those workshops to absolutely try and engage with as many stakeholders as possible, to try and bring people along with the idea, and even to get their insights into the way forward, because it wasn't clear right at the beginning, was it, Lee, as to what was happening? So it was all about that stakeholder engagement, and really get them thinking.
Yeah, there's a vision of where people felt they wanted to be, but we really needed the stakeholder engagement to hone that down so that we could start to work out how to get there, really.
Thank you. Any other comments? Questions?
Can I ask a quick question?
Peter.
Hi, Lee. Just a quick one, Lee. How does the SPA model fit into the new care groups for this new trust operating model, if I may ask?
Well, as far as I know, we'll sit under the arm of the community, and and so that's where we'll sit within the care groups. But of course, one of the things that we have found as we've rolled out SPA is there are many interfaces with all of the care groups, which will continue going forward. And so the work that we've been doing in terms of understanding the pathways for service users through our own organisation won't be lost, because they'll still be relevant when we're working from the community and interfacing with the other care groups. Yeah.
Thank you. Any other questions? Well, I would say it's been an excellent piece of work so far. Well done to Lee and Emily and everybody who has been involved with that. And a really good example of how you can take QI for a big programme of work and use it for those small PDSAs that then can be really, those iterative cycles going forward, and then to spread them as well. So great work. Thank you, both of you, for presenting today. And I'm sorry for all our presenters today that we didn't have as many on our showcase, but those that have been here, I'm sure, have really enjoyed listening to you, and hopefully learning and taking some things back, some ideas back to your own areas of work where you can spread some of the change ideas. So thank you very much. Are there any final points anybody wants to make or ask? Elizabeth.
Hi everyone. So my name's Lizzie. I'm the infection control matron. I've just joined the trust a couple of weeks ago. My colleagues are running the vaccination programme at the moment, so I just figured there's loads of people on the call. Let me just encourage everyone, if you have not done so already, please do go and get vaccinated. I'm not here to sell you on it and do like a whole sales pitch. What I'm going to say is, if you don't want to get your vaccines, or if you do, we've also got a survey. I'm going to add the survey link in the chat. It just helps us to understand, why do people get vaccinated against flu, and also why are people hesitant. It is really important for us, so we know how to support everyone moving forward next year as well. But yes, I'll also attach a link about how you can book in your flu jabs.
Thank you, Elizabeth. That's making every meeting count, isn't it? There, Karen.
I'm going to add on to make it count. Elizabeth, does that count for COVID as well, or is it just flu?
So we are only offering flu jabs to staff this year. If you do want to get your COVID, I'd recommend that you speak to your GP or your pharmacy, because they've got different eligibility criteria. But again, the eligibility criteria is available on the intranet. But yes, so flu jabs. Okay, but I'll add the links in the chat. Thank you.
That's brilliant. And I suppose whilst in view of the fact we are talking about QI, one of the things that I just want to bring to those of you here who are sort of probably band 6 to band 8A, we have some opportunity for some free training from NHS Impact, which is being provided by KPMG, Operational Improvement Managers Training, I think it is. And it is 1 day for a core module that for us is going to be provided at the rooms are available at Tabby, Stock and Portman, and then you do a half-day module in a number of areas. That one of them is mental health. I think Sian has just put the link into the chat. Is that right, Sian? Thank you. So if anybody's interested in that, it is really for operational managers, so band 6s to 8As. Okay, thank you very much, everybody. Really lovely to see you, and I hope that you enjoy the rest of your day.
Thanks, everyone.
Thanks, everyone. Bye.
Thanks.